Okay, we're recording. And good evening. It's Wednesday, not Thursday. It's Wednesday, 21 October 2020, 1901 hours. So this is just going to be kind of a review. There's three things I want to accomplish tonight. The first is to talk about the data to information to knowledge and wisdom framework, because that's the underpinning of this assignment. The second is a discussion about structured and unstructured data. I just want to go through there and maybe just pick out a few comments, some scenarios and stuff like that, just so you understand. I might, depending upon time, talk a little bit about why that's so important as far as structuring these electronic health records, these databases. We'll see how that goes. And then talk through, if you have any questions about the assignment. I've talked to a few groups and filled a bunch of emails and stuff like that back and forth. So we'll just spend a little bit of time tonight as just kind of work through some of these concepts and then field some questions, and then we'll do a free-for-all here at the end here. How are things going? We're kind of almost on the back end now. We're just kind of past peak, just like the trees here in Colorado, and we're looking forward to finishing up probably somewhere just after Thanksgiving. So far, I've been real happy with everything I've seen. You guys have been doing some really good graduate work. Not just a couple of things, but that comes every semester. And first, let me ask, is there any overall questions or issues? And I'll get to the specific things on the assignment, but anything burning issues or anything like that? Okay, you getting your money's worth so far? Okay, I'll just ask it, Someday ask me about, I actually started my own business back in the late 80s and 90s, and I don't want to talk about it tonight, but just remind me. Dale, you remind me, it's a really great story about how that all occurred. It actually came out of my master's thesis project. It was an air ambulance company, but I'll talk about that another time. So I have a very business framework about nursing, which kind of underpins a lot of the things that I've written about and things like that. Data to information to knowledge, and then ultimately to wisdom. What does that mean, and why is that so important as far as thinking about it, embedding that in your practice? Why is that important?
So I think it comes back to a lot of they had those signs up at one point where it said knowledge is power, and I always shook my head and said, no, it's not. It's the application, right? So we get data so we can collect information, but that doesn't really truly tell us yet. It becomes information when it has some sort of application. It becomes knowledge once we actually have a way to make it work in its own framework. And then wisdom's like figuring out how we kind of messed up originally and begin to apply it. It's like taking a class again, even though you've had some exposure to maybe the content, but you just didn't realize where you were kind of goofing on some of the little things.
Okay. How many of you have ever met or worked with a wise nurse, a really, really wise nurse? What was it about? What were some of the characteristics, the things that you noted about that nurse?
I think a big thing that I noted was kind of calm under pressure. And I think that came from their knowledge base and just being comfortable with that situation and having done it so many times that it becomes.
Exactly. And it's like they can predict the future, right? I remember when I first started in ICU, I remember some nurses had been there for a long time, and they start saying, "Oh man, this patient's gonna crump on us." And I'm looking at this, and sure enough, an hour or so later, there was the patient just kind of, just deteriorating, and they just knew there was just these subtle signs, these cues and stuff like that. It's called the knowledge embedded in practice, and that comes out of how many of you are familiar with Pat Benner novice to expert concepts? Have you heard? Marcia here, and is it Arla? Is Arla? Am I saying that right? Okay. And that she actually came out with that late 70s, early 80s, and interesting, it came out of aviation, and she was two researchers, Dreyfus and Dreyfus, were looking at expertise, especially in cockpit management, resources and things like that. And it was, and Pat Benner, who was a nurse, she was at San Francisco, University of Colorado, San Francisco. And she actually took that work and actually applied it into nursing and came up with this framework about how we move from novice to expert. How many of you remember right after you graduated in your first job, especially in those first few months? How many of you remember those things? It was terror, wasn't it?
It was awful. It was like the worst year of my life.
I still have nightmares about this. I mean, I'm serious. Like, did I get that guy his meds and stuff like that? It was crazy. But what was it about being a novice nurse? And again, I got to back into this, talk about this data to information and knowledge form. I just kind of want to use that as a good way to kind of frame the question. What was it about being a brand new nurse?
I just felt really cumbersome, and I was trying to remember how to apply everything that I had learned at school. And
Very task process oriented. Okay, good.
Totally. And trying to get my own flow. You know, I think nurse has their own rhythm and flow, but it's almost like you need structure in the beginning as a beginner in anything. I think you need a lot of structure, and then as you get more experience with the structure, then it's almost embedded in your brain, and then you can kind of expand out, and you have more kind of the wisdom to access when you really need it. I don't know if I'm
No, that's good. But again, we can remember that first transition, that first job was like, oh my God, everything was new almost every single day. And like, I remember just going, when I worked at ICU, I go into the room and I go, damn, I forgot something. I go back and get it and come back in, and it's like, oh, I forgot something else. But again, I was just so task driven. And as you think about your transition now, you're back in graduate school. So all you guys are experts in what you've done so far. Would you agree with me on that? You're good at what you do, but now you're transitioning to new roles. How many of you are in an advanced practice track, clin spec, including things like that? So again, you're going to become a novice again because you have to transition to that new role and relearn, and you have different roles, responsibilities, things like that. So let's kind of back into this whole idea about data to information to knowledge. And think about the data, the massive amounts of data that you work with every single day, every single shift, especially if you're in patient care areas. We did a thing, I guess it was a real, I worked in the surgical ICU, it was a trauma surgical ICU in Texas at the UT Med Center. And I guess one shift, it was just really just quiet. I don't know why, but we started counting all the individual pieces of data, and each patient had hundreds of different individuals just for that last 24 hours. And think about accumulating that over time. So all those pieces of data have some meaning. They represent some phenomena or some characteristic, some process and things like that. That's important. But we all remember, if it wasn't documented, it wasn't done. So it represents the actual care that was given to the best that we can represent it in the data we collect. But there's never, ever 100% complete record of them, literally reliving those moments. So what are some of the things in your practice that are important to you as far as collecting data? We'll get to information in a minute. But I just want to talk about the data themselves that you're collecting. And just tell us a little bit about the setting.
I can think of two ways that I use, just raw data. I work in the neonatal ICU.
Okay, NICU nurse, good.
And it's a level 2. So a big thing is bilirubin.
Billy's, okay,
so whether or not a patient, a baby can go home or not, or whether or not they need to go under phototherapy, you look at the trend and you have to look at, there's actually like a chart in Epic that tells you exactly, depending on the day, depending on the hour of life, if they're, what risk they are as far as hyperbilly. Another one is when they're born, you have to go into the growth chart and see if they're AG or appropriate as far as size, small for gestation or large for gestation. If they're small or large, then that says that you have to get, record blood sugars just to make sure that they're not hypoglycemic. So those are two,
especially the preemies.
Yeah, those are kind of like the big ones that you actually, use data specifically, and that kind of like guides your care. And there's actually charts in Epic that do the work for you.
Great. So just talking about the data themselves before we talked about, and I'm going to use this as a great example. I started NICU back in, God, 1980, I hate to say that, probably before some of you were born, but you talked about data, information, knowledge in that whole exemplar. So I want to pull out some of the parts, the component parts. So what was just specifically the data piece of it that you just explained? You're in a NICU, this could be any inpatient care setting, but what was the data, the individual data?
Blood sugar,
Blood sugar.
hours of life, and percentile, like growth percentile, where they plot.
I'm going to set that aside. That's putting it into a context. That'll be our information piece. But just the date. You're talking about bilirubin, blood sugars. What else in the neonatal intensive care unit? Has anyone else here done NICU or peds? Yeah, that's right. Yeah, okay. So what else is it? What are the other things that you collect a lot of data about?
Baby's weight.
Weight every day.
Yep.
You still doing them at 12 midnight?
Yeah.
That's when we used to do it because that was the quiet time after we transit. We were working 8-hour shifts back then. All right. All right. What else? How many? Nobody here gives any meds, right? Especially you don't give any meds in NICU, do you?
Yes, you do.
Lots of them, right? All right. So what's the data points in giving a med? Now you got a complex set of data. All right. What are all the data points? Data around giving just one med. Let's say you're giving them hanging antibiotic, whatever,
Concentration of the med.
The med itself, what the med is. All right, what else?
Dosage of the medication.
Dose, okay.
What else?
If you give formula because sometimes formula is given in NICU, right? Or even express breast milk, you have to record that.
Okay, again, all right. Yeah. So there's certain characteristics of whatever you're actually administering to the patient. The time, right?
Right.
The actual time. You guys record who you are because you were the nurse assigned to that baby or that patient. So, all right, what else? The baby, there's some kind of indication who the baby was. It's usually a medical record number, some kind of, a process number that uniquely, and this is important, uniquely identifies that individual baby or patient and no other patient, right? Okay, what else? The route, right? Oral, gastrostomy tube or NG tube, things like that, intravenous, those types of things. All right, so again, I don't want to belabor this too much. I just want to say, just give you a sense as far as in nursing and healthcare, there's very few simple data points. There's a lot of things that are connected to that individual process or intervention things that you're doing. All right, so let's go back to the bilirubin. Now this is 40-year-old knowledge, so you set me straight if I go off the beaten track here, but there's two different types. There's different types of hyperbilirubinemia or jaundice. Let's just stick with jaundice. So there's physiologic jaundice, which is fairly benign, but there's also jaundice related to babies that are getting septic.
Mm-hmm.
Okay, so let's begin to piece this together from an information standpoint. So you talked about a nomogram as far as just for the bilirubin number. There's a range. There's a physiologic range that basically for a living for a living baby, for a living person, that there's a physiologic range: normal, high, low, and then there's critical values. We talked about this last week, didn't we, Elizabeth? About the critical values and things. Okay, so that puts that piece of information in context. So what would be a normal bilirubin for, say a normal weight, normal gestational age baby? What would be a normal bilirubin?
Well, the thing is, it depends on the hours of life.
Okay.
Like how old they are.
So it changes over time. All right. Okay, good. So it gets higher a little bit, then it goes, it starts to go down after, and I can't remember the time frame.
If you have like 24 hours, you want it to ideally be below, I don't know, 5.
3, 4, 5. That's right. Okay. All right. Good. All right. So if you took a bilirubin at midnight, because the baby was born right at midnight, and for some reason they were in the NICU. Well, they were in the NICU for jaundice. All right. How's that? and you took initial bilirubin, it was, let's say it's 7. That's a little on the high side from what I remember. Okay. What does that one data point in context tell you? I'm being tough here tonight. I'm gonna throw some patho in. Elizabeth should be
Well,
ready for this one.
I mean, do you want to
Okay.
like the reason, like the pathophysiology behind it?
All right, what is bilirubin? First, tell it. Who knows what bilirubin is? Raise your hand.
Bilirubin is a byproduct of the body breaking down of red blood cells.
Red blood cells.
So it
Good.
has, okay, so it goes to your liver, and for adults, we just process it. Our liver, kind of like it's kind of like a byproduct, so it's like waste. So our liver gets rid of that. What happens with the babies is their liver is not mature, so it doesn't function as well as an adult, and it doesn't get rid of that waste as easily. And
Okay,
when
good.
that waste, it can go to it crosses the blood-brain barrier, and it can cause kernicterus, in other words,
Excellent.
brain damage.
Okay.
Which can cause seizures and death and other.
You got it. No, you got it. Yeah.
ways.
Yeah.
So,
So the other thing we need to talk about, so you just talked about our knowledge or understanding about bilirubin, how it's processed, things like that. So let's talk about causes of hyperbilirubinemia. All right. One's physiologic jaundice. And what is that related to?
immaturity.
Who knows? Who knows the answer to this? Physiologic jaundice. My mom said I had it. She says, I was the most beautiful, ugly baby, and I was the first one. I was a little bit post-date, and I was peeling, and I was orange because I had physiologic jaundice. And what do we do with babies with physiologic jaundice?
Put them in the sunshine.
Put them in the sunshine. Sun their buns, okay? So here's the important piece, because you're collecting data. You're seeing signs and symptoms. So jaundice in a newborn, 24 hours post delivery, that's a sign. That's somewhat abnormal. Now there are certain things that are fairly easy to treat physiologic jaundice, and that's related to placental transfer of blood into the baby. It happens during delivery, and for the most part, if the baby gets sort of an infusion of red blood cells, their body will eventually, again, a normal, healthy baby, good weight. They're feeding well. You're going to hydrate them. You're going to use using either photolights, or if you're in a smaller unit, or even in developing country, you put the baby in the sun, and the body will break that down. All right. We know what the etiology is as far as the jaundice is related to the breakdown of the red blood cells. All right. So that's our knowledge piece. What's the information piece in that process? All right. You're taking bilirubins, midnight. All right, went from your first, when you admitted the baby, it was 7. All right, they were a little yellow. Okay, they were, I don't know, they were about 7 pounds. What's that, about 4 kilos or something like that, somewhere around there. Fairly normal weight, 4 or 5 kilos, something like that. If you took the bilirubin at 6 a.m., so you do morning labs. All right. If you went up to 10, now you have some context right now. You're seeing changes over time. You do this every single day, every moment of patient care. You're looking, you're comparing, you're seeing, did something change whatsoever. I mean, we could sit here for hours and hours talking about all sorts of clinical examples, but there was a change. That change is relevant to the underlying condition. So if the bilirubin went from 7 to 10, what's your nursing brain thinking right now? So you got some additional piece of information. You've got 2 data points, a bilirubin of 7 and a bilirubin of 10. I know 10's high. All right. What is that telling you?
No, it's getting worse.
Something's getting worse. You're not quite sure what's going on, but something's getting worse. All right. Assuming it's good data. All right. So what would change? So let's access our knowledge base right now. What do we know about, and you basically answered the question, but what do we know from a nursing standpoint about high levels of bilirubin? You just answered, but just go ahead and reiterate it for purposes.
It can cause brain damage.
Yeah, that's the one of the most severe, yeah, at really, really high toxic levels that could actually lead to cardiovascular collapse and death and things like that. But we're trying to reduce or minimize risk by the types of things that we do in the unit. So you can hydrate. What else?
Phototherapy.
Phototherapy. What else are you going to do? What we do all the time, continue to monitor. You're going to retake the lab. You're going to put that into context because you're going to do something now. And then you're going to reevaluate. Is this the nursing process, guys? I'm just putting an informatics spin on it just so we kind of understand. Now, in Epic or whatever electronic health record that you're dealing with, more and more we're going to automated processes, prompts, warnings, those types of things that not only can you see the change, whether they're graphics or whatever, or warnings, but that you can actually access the knowledge base that's embedded in the electronic health record. Say, hey, what does this mean in 10? If I was back in a brand new grad, I didn't have Epic back then. We had pencil and paper, that was it. And we had these things called books, but that's a whole other story. When we start thinking about changes over time, we're looking at not only what's normal and what's starting to get abnormal, but what are the critical values? Because the further away from normal, the more dangerous the condition becomes and the higher the risk as far as all sorts of things. All right. So that's why all this is, I mean, you do this intuitively, but think through all these different processes that you do, day after day after day. All right. So let's take another, let's say you're doing well hydrating, you're taking a temperature, and again, it's a normal newborns, all of a sudden their temperature's going up. Ooh, I just threw a new piece of data at this problem. They had a normal temp, and now they went to, okay, should I go metric or American? Metric, like I can do, well, let's do it as in American. So they went from, maybe like 99 up to, now they're 102.2 or something like that. Yeah, Monica, your brain's starting to go, this ain't normal. Something's wrong here. If this kid has physiologic jaundice, what's the possibility that a fever is associated with the jaundice?
Sepsis. Infection.
Okay, so you just recognized a pattern based on a constellation of symptoms. After you've done it enough times, you can look at a Billy kid and say, and it's just normal Billy, we'll just keep an eye on him, versus, no, this baby's going to get sick. Something's not right. You're not quite sure, you don't have enough data points or information to know it, but that's where that expertise piece comes in. You've seen this time and time again. There's just something about this baby that tells me this is not going well. So what would you do under these circumstances?
Probably draw labs, draw culture, draw CBC to see what the baby's.
All right, so you go ahead and do a culture set. All right, good. All right, so now you change your thinking from something that looked like probably just a normal baby, was maybe just physiologic jaundice. The data supported that clinical judgment. Now all of a sudden you're beginning to see some new anomalies, temperature in this case. And if the baby was truly getting septic, what other data might you see? What characteristics of the baby that you record?
Probably require oxygen at some point.
Okay, yeah, oxygen levels start going down, or their sats start going down.
Probably lethargic.
Yeah. The baby was crying, being fussy. Oh yeah, if you were being handled like that, sure, you would be. But when babies and kids go quiet, that's when our nurses' brains start going into that. That's not normal for a kid to be lethargic, stuff like that. All right, what else?
Tachycardia.
Tachycardia could be related to the fever, but again, that's all kind of wound up together. What else? This is a
Low
NICU
pressure.
now. This is a NICU.
Pressures would probably be low.
So maybe some respiratory component here. All right, nasal flaring. All right, things like that. Okay. Now, for those of you who here has never worked in pediatrics or NICU or anything like that, okay, even just talking to you haven't worked in this setting. Are you starting to get nervous about all this stuff? there's
Yeah.
again, the data is just,
I'm
you know,
I'm
once we-
nervous the minute that you say that it's a baby.
oh, it's a baby. Well, I'm just the opposite. I don't care about the baby. When I say, oh, I got a pregnant mom, oh, no, no, please. No, no, no. Go see Gretchen over there. She used to work OB. Yeah, she'll take care of the patient for us. So is this helpful as far as beginning to think about moving from data to information, how knowledge is all embedded? We do it sequentially, but in actuality, we all multitask. We do this simultaneously. And the new moving to an electronic health record, because we collect these data in various forms, that's sort of a machine readable expertise. What I mean by that is, think about what was going through your mind when we started, portraying this scenario. The bilirubin's going up, there's some changes in the heart rate, things like that. But all of a sudden we threw in temperature. That was a threshold. That was a threshold that totally changed how we thought about this. And that's what the algorithms that we develop based on the data do. They're looking for these subtle cues, these patterns, and that they can mimic human expertise, just as Pat Benner had said, just by looking at these various patterns and the trends over time. Does that make sense? I just kind of want to give you a sense how all these data that you're collecting every day, every shift, and how they can be useful, not only for identifying the care that was given, but also the data themselves are useful in developing algorithms and helping you understand trends and things like that, and actually accessing the actual knowledge base that underpins everything that we do in the clinical setting. Can I tell you a quick story? I know I tell stories, but can I tell you a quick story? This is actually something that really happened. It was one of the first babies I took care of. I don't think I was even in the NICU for 6 months before this happened. But same deal. I worked at New York Hospital in the NICU. That was my first job. Fortunately, like when I was in nursing school, I was in the transport team. So I was one of the paramedics that would go out with the docs and the nurses to pick up the baby. So at least I was familiar with what was going on. Same thing. I was in what we call the back room. There's sort of the step down unit, and they just brought in a baby from New Jersey, and her name, I'll just say her name was Emily. And we put her in the bed. She was jaundiced, but she was, normal birth, normal weight. Nothing ever really of concern other than her belly was fairly on the high side. We put her on phototherapy. We were hydrating her, oral hydration, stuff like that. And during my shift, all of a sudden, she just crumped. She just got lethargic. I'm like, something's not right. The resident came up and said, yeah, let's get some labs. Her belly was up to, I think, 15 or something like that. She was starting to, she was starting to get mottled and things like that. So we brought her up front. They intubated her. And in the course of about 6 to 8 hours, she went into multi-system failure. Her liver shut down. Her kidney shut down. She was probably the sickest baby I've ever taken care of because it happened so fast. It wound up, she had cytomegalovirus. They were actually able to finally find it. So she had viral sepsis. That's what was going on. And it was interesting. I mean, her mom was at that kid's bedside 24/7. We couldn't even convince her to go back to Jersey. Not that they want to go back to Jersey, but it was just, I don't know, it was just something about this baby that we just gave the 101%. And we worked as hard as we could. It took that baby, oh gosh, almost 6 months. She was in the unit for a long time. We were able to get her kidneys jump started, and her GI tract started working. She was really. They did exchange. Monica, do you guys do exchange transfusions? Do you guys know what that is? So you're taking the old blood back and putting new. Yeah.
I've done it twice in my career. It's pretty rare. Yeah.
Yeah, it's pretty rare. But again, it's a way to avoid problems as far as brain connectors and things like that. So I wound up leaving New York and I went to Houston, Texas. That's a whole other story. I felt like I needed a passport when I got there. That's how different it was. But I guess it was about 2 years later. In fact, I went from NICU to adult shock trauma. And I think the first words out of my mouth the first 3 weeks was, you want me to give that whole bag of black-headed ringers? And you got to give another one after that. I said, we're going to kill the guy. I said, no. But some of my old colleagues went and every year we had, you probably have the NICU parties that you bring back all your graduates from NICU, and you have, it's usually around the holidays, and it was the following year, I guess. And here's this beautiful blonde kid, and it was Emily. And I got a nice note, just, she's a perfectly normal, precocious kid, and boy, we did a great job with her. And that was just one of the wins. So, you know, you just kind of, every once in a while, you need a win like that. I know it's kind of an off the beaten track here story, but again, it's kind of that qualitative thing that we do from a nursing standpoint. It's not all about numbers and letters and stuff like that. It's the added value that we bring, and that what that does is produces really good outcomes. So anybody here in the iLead program, as far as looking at outcomes? So if you're examining outcomes, you know, having something like that as far as being able to qualify and quantify the care that nurses give and look at those outcomes. Here's a perfectly normal baby that was about as sick as you can be, but the, you know, the actual interactions and the teamwork that was involved with that care produced this really good outcome. So, well, I've covered a wide gamut here. It's only got 32 minutes into our session here this evening. So, all right, that's kind of the data to information to knowledge framework. And you can quote me, says, it's not a sequential process. It's a multi-process. We're all doing these same things over and over again simultaneously. All right, let's talk a little bit about structured and unstructured data. So this one's fairly easy. If it's a number, you can put it in an Excel spreadsheet and do all sorts of calculations on it. That's a structured piece of data. If you're, how many of you have the, you and like patient demographics, you know, you're doing your initial intake form and stuff like that. So, you know, you have these drop down boxes. It's a forced choice. Okay. So, you know, gender, male, female, other, or something like that. All right. So you've got three and only three choices, and you can only select one. So it goes into the database as that choice. How many of you write narrative notes? Do you guys even write narrative notes anymore? I used to love writing these long, you know, things. The problem with the narrative note is, how do you actually extract data or actually move it to information? It's hard. Now, like I said, with structured data, it's fairly straightforward. You can look at if you have the temperature of all the babies in the NICU. Someone asked me that. I've used this as an example as far as, you know, some of my research. They go, why would you want to do that, John? Says, well, number one, you can tell how many babies are hyperthermic. They might have too high a temperature, or too low, especially the preemies. That's not good. So you can actually use that for surveillance. You can use that for example, Monica, if you're looking at infection rates and things like that. So you can use these structured data fairly easy to actually look at key points and things like that. But if you had nurse write, the baby's temp was high and it was low at the beginning of the shift, now it's high, they didn't really put anything in there. How can you actually extract that from the narrative data? It's hard, but it's not impossible. That's called natural language processing. It's not 100% accurate, but you can use narratives to actually pull out key words, key sentences, things like that, and come up with some idea as far as what was going on with that care. All right. So again, structured versus unstructured is how we actually capture the data in the electronic health record. Now, I was thinking about talking about constructing databases and things like that. I'm just going to talk real vaguely about this at this point. How many of you are in the informatics program? None of you are informaticists? All right. So if you're in the informatics program, the master's program, you actually have to take a database course. How do we actually structure this? Now think about it for a second. If you're writing this on a note, you know, a structured form, you know, you've got vital signs and you know, different things that you can put, you know, meds and things like that. And then there's narrative notes. You can actually draw graphs and stuff like that. If you were trying to produce some kind of information, trying to look at trends, bilirubin trends in NICU, you want to know how many babies had this, or maybe you're a referral hospital and you're getting a lot of these physiologic jaundice patients from level 1 and level 2 nurseries. That might be something that you can go back and say, well, let's go ahead and do some education interventions there. So maybe there would be fewer transports, but you need the information in such a way that you can actually begin to see that. All right. So how many of you have actually done statistics? I'm sorry, I always get that wrong. Statistics. I need some more here. So if you were just doing simple means and stuff like that, well, if you had a number, again, let's just look at temperatures again. What are some of the things that you can do with a group of numbers? You have the same baby, the same person, others, across different settings and things like that. What can you do from just an operation standpoint? You can do a mean. What does a mean? What is a mean? Or an average? We can talk about averages here. Yeah, go ahead, Dale.
Well, yeah, you can average the numbers over time. You can get a trend that will show you increases or decreases over time.
Okay. Trend lines and things like that. Good. You click average versus outliers or something like that. And if you work with flow charts and things like that, you're trying to keep something within certain parameters. And if it goes out of trend, most of those are doing quality improvement types of activities like that. So again, if it's a number, you can do these kind of operations. So if we took the average, and let's say you have a medical record number, it's just a set of numbers. What would it mean to take the average of the medical record numbers? It's a trick question.
I don't think that would give you a value, actually.
It's
It
not
might
since it's meaningless.
Well, it might suggest the midpoint at which you've had a group of people come in. I mean, that would give you kind
Well,
of.
that's a big stretch, but I'll take it. But for the most part, the reason I'm bringing that up is numbers can sometimes be characters. They're just a class. So whenever you have like a social security number, if I took an average of the social security numbers, it would be meaningless. Even though it's a number, it would be meaningless. So sometimes there are numbers that are used to, like that drop down box. What may happen is instead of storing it as MALE, FE, or whatever, not whatever, that you want to store the number because it takes up less space, but you'd have to reconvert it back to if you're doing some kind of analysis. Again, if you're just doing simple demographic. So if you had male, female, let's just start with that, and race. What kind of things could you do with that if you were just trying to look at trends, characteristics, and things like that?
You could get an idea about your population that you're serving.
But if you were analyzing it, the actual data themselves, what would it look like?
You mean like male versus female?
So that would be expressed how, though? Percentages, right? Or numbers and percentages. Does that make sense?
It could be percentage, yeah.
Yeah. So it's different than taking a mean. It's just a percentage. You're looking at the proportion of male babies versus female babies in this situation. Now, let's say you asked another question. Let's go back to our bilirubin. You want to look at trends, and you're asking questions. I just seem to get more female babies for some reason, so that you can actually go back, look at maybe a whole year's worth of data on all the admissions, and then identify babies that got septic or they had hyperbilirubinemia, okay? And then you're trying to better understand and organize that. So for example, you might say, well, it looks like in just our Billy kids that 60% of the patients are female and 40% are male. So, okay, that's interesting. Or you could look at gestational age, and let's say that you actually categorize, instead of putting it as a number, you went usually, what's the lowest gestational age, Monica, that you see? I mean, I understand that they're viable 22 weekers now. Is that true?
Yes, but I think yeah, I've seen like a 22 and 5, 22 and 6.
Okay, so it goes down. When I was doing it back in the 80s, 26 with the line and saying, anything low, and usually that was not very viable at all. Those kids had horrible outcomes.
They still do, really small ones.
Yeah, the really, really small ones. But again, that's meaningful because now we can say, well, all right, let's look at the outcomes, for example, of the really premature babies, say less than 28 weeks, then 28 to 32 weeks or something like that, and so forth. So now you're trying to do some analysis as far as, well, what's the outcomes of these babies? So Monica, I keep picking on you, but I just want to make sure that I'm getting this right. So what are some of the common outcomes, some of the bad outcomes from NICU babies, especially premature babies?
A lot of them end up with intraventricular hemorrhages. That's pretty
They're
common.
still getting that? Okay.
A lot of them end up with retinopathy of prematurity. because of
Retinopathy, and that's
oxygen.
usually related to the oxygen levels and stuff like that. Okay.
I'm not sure about percentages, but necrotizing enterocolitis is pretty common.
Necro,
I mean,
yeah, we usually call it necro. Yeah. Okay. Do you guys know what necrotizing enterocolitis is? The gut, the perfusions of the gut stops, and basically the gut just basically dies, and that's that's a really bad thing. Okay. You get BPD, bronchopulmonary dysplasia. Okay.
not as much because we try to start them on CPAP. I mean, it used to be where you just every, preemie was intubated. And now we've moved towards intubating, giving surfactant, and then extubating as soon as. So BPD is like almost a thing of the past.
Yeah,
Actually,
I was in
speaking
NICU.
for the neonatal cardiac population is who I've worked with, and that's actually BPD is still pretty prevalent.
Is it? Okay, yeah.
Yeah.
But the surfactant thing, I did NICU pre-surfactant, and those kids had horrible outcomes because their lungs were so immature, they couldn't expand their lungs. There was no surfactant. We blow a lot, high pressure, 40, 50 centimeters, just to physically expand their lungs. Surfactant is one of those true miracles of modern medicine, that being able to give them surfactant helps them expand their lungs, so that decreases these bad outcomes such as BPD. So again, I'm trying to give you a sense as far as how you collect the data, you organize it and store it, gives you the ability to begin to look at things like, looking at population and outcomes, changing interventions and things like that. So that's structured versus unstructured data. I'm not going to talk about how we actually set up these electronic health records. It would take me probably an hour or two just to even give you the basic information, but I just want to say this. The way that these electronic health records are constructed, I'm assuming all of you work with an Excel spreadsheet or something, or Google Sheet or something like that. It's rows and numbers, all right? So imagine you're just collecting raw data. That first row gives you some sense as far as what those data are. Let's just say vital signs. So the first row across is medical record number, okay? And then would be like a date time stamp. Then might be heart rate, blood pressure if you're taking that, weight, those kinds of things. All right. So if we wanted to store information or actually look at information on characteristics, male, female, ethnicity, things like that we probably need another table, because we want to put all the things, the characteristics of that patient every time we collected that. That wouldn't be very efficient. In fact, if we stored it that way, it would quickly blow up to this really, really large data set that was not very efficient. So what happens in modern electronic health records, as far as the database, they use what's called relational databases. What that means is that if you have a unique identifier, in this case, a medical record number, you don't have to keep storing all those patient demographics. You can put them in a separate table and collect them once. And what happens is, if you need those data, you have a link between the two tables. And I won't get into all the things that happen, but you can actually pull those data in like you were doing a query, and those data are available. So it keeps the data very efficient as far as how we structure it in different tables. What happens in something like Epic? How many of you are using Epic? That's probably the most common electronic health record. Any Cerner folks here? Cerner, okay. What am I missing? Cerner. Sunrise. McKesson, I think they got bought out. Yeah, something like that. Cerner, McKesson. The HCA folks here, I can't remember the name of that. Okay. What are you using?
Well, it's Meditech, but in
Meditech, that's what I'm thinking of. Yeah, Meditech, which is built in the year 1900 or something. I'm sorry. Meditech's been around for a while. It's just a quick question. are you the student that's working at Ridge, or whatever it is, Sky Ridge?
I'm at TSL downtown.
Oh, okay. Are you collecting the nursing codes, the clinical care, Virginia Sabas? You're actually using nursing codes and diagnoses and things like that?
Ooh, not that I.
Okay, I was just curious. I work with Jane Engelbright. She's your vice president for nursing. She's out in Nashville, but she's really big into informatics, and I just wanted, I just want to see if you were using that, but that's a whole nother story. But there are different platforms, software platforms, but they all use the same basic set as far as they have multiple tables. A modern electronic health record in an acute care setting probably has well over 1,000 different individual tables. There's a lot to keep track of. And you really need the data scientists and the IT folks to work closely with the clinical folks to make sure that you're doing this, collecting this data in as an efficient way as possible. How many times have you actually gone into the electronic health record, Epic or whatever it is, and you're trying to find a form to put stuff in, and it gets kind of buried in there? It's not necessarily a problem with the database itself. It's how the database is connected to human beings in that user interface, so that the interface design actually does queries on that back end, all those different tables, and arranges the tables and stuff together that they can pull out certain types of information. For those of you who are going to go on and use data in any of these EHRs for whatever reason, either your DNP project or your ongoing efforts when you finish the program here and you're in advanced practice roles and things like that, find someone who's really good at working with those tables in order to extract the information you might need, and then you're going to use your own clinical judgment as far as looking at whether it's a QI project, whether it's a clinically focused project, and things like that. And some of the things that you're getting exposed to and learning in this class will help you begin to think about, all right, you may not know exactly how to do a query to pull those data out, but at least you've got the big picture. You can go ahead and organize the data and then be able to work with either yourself or others to go ahead and begin to do analysis on these very complex data sets. Any questions so far? Is this halfway interesting? Is it? Sometimes I see my students when I talk about this stuff, they get glassy eyes. Says, yeah, but this is important because that's the data we collect. That's the holy grail in there to help us better understand not only nursing care but all of healthcare. So if you have at least a rudimentary idea how all this stuff is structured and how it works, that gives you at least a good jump as far as being able to use those data, not only for your day-to-day clinical care, but also for other things, to be able to look at outcomes or costs or anything that is important questions to ask and answer. Okay, so I'm going to grab a swig of water here. What questions do you have about the assignment?
So just getting a little specific for the knowledge section. If we are referencing studies, I'm working on that section. I'm using a meta-analysis and a randomized trial. They are older sources because they are the ones that have been referenced over and over and over and over again. These are trials that are now influencing hypertension care.
Excellent, good.
Still.
So you found a classic study, yeah.
Yes, yeah. They're the ones that like the guidelines reference and all that kind of stuff. So they're older sources, but then how in depth do you want us getting in terms of describing the content of those knowledge sources?
So give us some context as far as what the problem is that you're going to be addressing.
So we're talking about hypertension, pharmacologic, non-pharmacologic management of a new onset hypertension patient. So the sources that I'm looking at are the Sprint Research Group's trial of aggressive versus not as aggressive treatment to lower blood pressure. And then I'm also looking at a meta-analysis of like 147 randomized trials of different antihypertensives. So looking at, kind of the pharmacologic part of it specifically for the knowledge source.
Okay. Now, yeah, go ahead.
Well, so yeah, I described the studies and, kind of the overview of what they covered, but didn't necessarily get into like the true conclusions of them, which was, what medication class would be more effective or anything like that. I just said,
Yeah.
kind of indicated that this is the knowledge source and this is what you would refer to.
That's
as the
good. And
definitive piece.
are you going to talk about genomics at all in your?
Was not planning on it.
Okay, that's
no.
fine. Yeah.
Yeah.
It's a real brief, just a data point here about genomics, in that we know that all patient responses are not the same to, for example, antihypertensives, that some patients metabolize them differently and things like that. So this is going to be the next step that you'll be involved with, as far as using genomics to help understand patients' response to pharmacotherapy. All right. One of the things that that's interesting about hypertension is that the numbers have changed. It used to be a few years ago, it was basically, I think it was age dependent, and it went all the way up to, I think, 140 systolic. And it changed. I can't remember exactly when it changed, several years ago, but then all of a sudden they brought that down because they were starting to see some outcomes in these mildly hypertensive older patients and stuff like that. So it depends upon, from the knowledge standpoint, you're using these guidelines based on science, the 147 studies that you demonstrated or talked about, and then there has to be some context within the knowledge. So you're going to treat patients based on a whole set of characteristics that were sensitive to different types of pharmacologic and non-pharmacologic intervention. So just kind of, you've already got the data and the information part of your paper, and then you're trying to incorporate that into clinical guidelines to help actually intervene in a population. This is one of the highest, hypertension is one of the highest causes of death rate in the country, especially on secondary conditions, as far as heart disease related to primary hypertension and kidney disease. So begin to think about that as well, as far as how is that going to help you better manage a population, but what are some of the outcomes if that management is not optimum. So again, an optimum management would be the right amount of drug, minimizing side effects of the drug, optimum wellness management, things like that. What are the things that cause hypertension? If you see a big line at Starbucks, especially if there's older people, you're going to be worried about them, because not only is that going to cause hypertension with all that caffeine and sugar, but it might also cause dysrhythmia as far as the caffeine. So again, think about that as well. But I won't deny that I haven't been to Starbucks every once in a while, but that's all I'll admit to. But so again, see how you're actually taking the knowledge base and you're using that to not only look at the entire population, but also to individualize the care for each patient. And that's part of that value equation. If we can optimize care not only for entire population, but each individual within that population, that will have optimum outcomes. Least amount of side effects, least amount of poor outcomes, cardiovascular disease, kidney disease, and the least amount of cost. So again, these are all the different trade-offs. Is that helpful, or did I get off the beaten track again? Okay, good. Any other questions? You guys are quiet tonight. Everybody talk too much.
I kind of have a quick question. I don't even know if we're on the right path, I guess, with ours. I am hoping, I don't know, hoping we're close. We're going to talk about falls in those with Parkinson's disease.
Okay, all right, good, yeah.
And I work with babies, so it's totally out of my, I don't know. Anyway.
Okay, yeah, I can see the dilemma.
Yeah, no. So anyways, we're
no, baby, not toddlers. Okay, yeah, I got it. Okay.
So we were thinking for information to use like history of falls, and then maybe the progression of the disease. Like, are those even sort of? It just seems very broad, but I guess.
Yeah, brains. It's not brain. What's the scoring tool that you're going to be using?
Well, yeah, there's
Falls
several.
risk.
There's several. There's TUG, and there's different ways to assess their motor capabilities. So we can talk about those. The history of falls, I was thinking some could be structured like if a fall has been documented in their in the system that they're coming back to, but if it's at home, it might be kind of an unstructured thing. Is that sort of
No, that's good. Yeah, I think, so
okay?
you know your data points as far as all the things that you're trying to collect about the patient, age, agility, or frailty, those kinds of things. All right. Mental status is going to be important.
Yeah.
Home environment is going to be important. Is this an acute care or home environment that you're working in?
Well, yeah, that's what I don't know if we need to choose specifically, I guess. I don't know.
Okay. So the context of the care, things like rugs and stuff like that. Animals. I have a little Manx kitty cat, and she's always at my feet. It's just I got to be really careful in the morning. I'm just getting up. She wants to be fed, and she's in there. It's like, oh, please. So again, things like that, especially in the elderly patients, can be, having the animal is great, but it could be a problem as far as increasing the risk of fall.
Sure.
I had a colleague, he was a faculty here. He went to Missouri a couple years ago. He was doing research using home automation techniques and sensors in the home to actually look at gait patterns. And it was interesting. What they were finding was that there were certain patterns as far as how the patient moved through the different sensors, just how fast they moved, the rate, and how straight a line, that was predictive of things like falls and mental deterioration, things like that. So even, again, there's a whole bunch of data points, but these are some of the things we're trying to predict who's at risk and then intervene. The other piece of this is we want to decrease the time between information and action. You got your knowledge, you know what to do, but if you don't, if a patient's at high risk for falls, but you don't do something for a week or two, that opens them up to potential falling during that time. So again, from an informatics standpoint, we're collecting all these data points, we're putting in context, but that there has to be an action point, an intervention, so that decreasing that, getting the information to clinicians so they can intervene as soon as possible is an important consideration in all this.
Okay.
So would that be an example of like a data element point then? So like for hers, for falls, that it would be one of your points where you would say pets, yes or no, that sort of thing for structured, and then the unstructured would be like the activity of the pet or whatever. And then
Exactly, yes.
And then, okay, so, and then data, another one would be potential like living situation, like whether they're in independent living, steps, all that sort of stuff.
Yep, stairs.
Okay.
Stairs is really hard for the elderly, those types of things. So again, that's a different context than the hospital. What's the first thing that happens if you have a falls risk for a patient in the hospital? You put a sticker up someplace to let everyone know that there are falls risks. Then you put those funny looking socks on with the little grip pads on them and things like that. So again, context is really important. That helps you understand not only the information part, the context of that information, but also how you apply the knowledge in different settings. So we know that there are certain interventions that are effective in reducing the risk for fall, but there are context setting specific. So, think through that. That might be helpful, Sarah, as you begin to think through as far as, really finish that paper strong as far as, here's some of the things that can happen in a home environment that you're trying to keep elderly in their home as long as possible before they go to assisted living. But again, there's a certain point, again, that's that threshold effect. There's a certain point where the elderly just can't function well, that it's becoming more dangerous for them to be alone. So that the intervention might be moving to assisted living or something like that. Is this helpful? Let's do one more scenario. Who's got another scenario for your paper? How many of you are on East Coast time? So I really screwed up on that email. Oh, God.
I was going to say something, but it's okay.
Oh, you should have, because I think we were doing hikes up to 12,000 feet the other day. So it's like maybe I got hypoxic at altitude or something.
You have haze.
Yeah. But
no, it's fine because I'm used to doing the mental math anyway. Every time someone says mountain time, I'm always thinking a couple hours ahead.
Mountain time, so you guys figure it out. I won't even say the other time next time.
Yeah.
Okay. Anything else? You know what my pet peeves are as far as writing. You got that essay, how to write a good essay. So think through that. I'm looking for a little bit better, probably the next step up: clarity, conciseness, Yeah, you got 6 pages, but there's a lot to write in 6 pages. FYI, I already told the group last week, but I'll tell the group this week. You can use single space. That's okay. If you're using Arial font 11 or 12, and Times Roman works better for me at 12 point. It's interesting. Times Roman is a more compact font. So Arial 11 is basically the same as takes up the same amount of space as Times Roman 12. In fact, if you want to do a quick little project at the side, actually go ahead and write it whatever font you want, and then change it to the other font and just see how physically how much expands or contracts and stuff like that. Okay. It's okay to write justify in my class. I don't think there's any other faculty that feel okay with that, but it actually is easy to read. Times Roman 12 and write justification actually just from a reading standpoint and from a fatigue standpoint seems to do about best. It's interesting because that Times Roman comes from the New York Times. It was actually, it goes back to the 1800s, I think, or something like that. They found that was the best trade-off between the actual physical space of the paper, because it cost them, pennies per page or whatever, and readability. So that's kind of some of the arcane things from an informatics standpoint for font sizes and types and things like that. If you want to go ahead and put an appendix in and put a big table, 1 page is okay. If you need to do more than that, just let me know. I'll be around this week all the way through. So, and I'm going to try to be real good. I just got finished with the grading of the last assignment with the discussion post. I've read through that. You guys did a great job on that. So I basically did a pass fail. So as long as you did well, you got 100 points or whatever it was for that assignment. And for this one, I'm going to try to get this done by like Sunday, Monday, and Tuesday or something like that. It's a group project, so there's fewer overall, so I'll be able to give you a little bit more comments, stuff like that. Probably going to be crying after the Broncos game on Sunday. Kansas City is coming here. They're going to beat our what, but I'll probably just say, turn the TV off. The heck with this. But again, I want to try and give you some good feedback from writing style and things like that. So if you have any questions, like I said, just let me know. Send me an email. Send me a text or something like that if you're really distressed, and I'll talk you down off the ledge. But I did make some accommodations from some groups, so I'll just leave it at that. And I think that's all we need to talk about tonight.
Real quick with the appendix, or if we want to put in a table, because again, we're adapting the algorithm from the hypertension guideline into like a EHR friendly, algorithm that we could use in that way. So if we put the algorithm, I couldn't remember what you said the other day about permissions to use the algorithm, or how you wanted us to approach that.
All right, so the guidance for this class and this class only, if you're cutting and pasting from a source or a table, a graphic, whatever, and that's fine. You have to cite the source directly under that, and you do not this comes under the fair use under the Copyright Act. What that means is, for one class, for this, it's not copyrighted. Your work here is for our private interaction here, that you can do it for one time only. You can't publish this. If you were to publish a paper and you were actually use something from another journal, you would have to go to the publisher of that journal and get direct permission. And then when you cite it, not only do you cite it where it came from, but you said, with permission from the publisher. I think there's a very specific language to do that. The other thing, as you go further along, you're gonna accumulate more and more things that you have written. Be careful of self-plagiarizing. And that's what that turn it in thing does. So as you turn in stuff, every once in a while it'll pop up, and I'll see stuff maybe you cut and pasted from stuff that you did in the past. Don't do that. That's not a good thing. So just a couple of tips and things like that. If you've written a paper like in another class and you want to kind of use the essence of it, just physically rewrite what you did and just paraphrase it, and don't do it verbatim, things like that, because that will sometimes pop up and could be an issue with other faculty, things like that. The worst one I had was, I think I said this already, but the worst one I ever had was a PowerPoint presentation. It was an online PowerPoint presentation. And I got a tip from another student. It says, look at this website. And sure enough, it was exactly what was taken off of the website. The only thing that that the student changed was the copyright at the bottom of the page. He took that out and we had a little conversation. And so just don't do things like that. I know you guys are savvy, but just be careful. It's so easy to cut and paste information, and that can get you into trouble somewhere down the line. So just don't do it. And if you have any issues or you just want to throw something by me, is this okay? I'll talk to you and we'll see what it is like that. So that's kind of a long answer to your short question, Elizabeth. How's things going with your other classes? So Dale, you going 100 miles an hour, right? Because that's all you got in school here is like, oh.
Yeah, we're in stats right now.
Oh, good. How's that going? Who's teaching that?
Dr. M,
M. You muted. He doesn't know his faculty's name. That's not.
I can't remember his name. It's Mosca or something.
I don't know that person. Okay. But this is the inferential stats or whatever they call it, the basics. Okay. All right. I hated in my master's program, I hated that stats class because I was a clinician. I was like, and it wasn't until I got to my PhD program, I went, that actually was pretty good stuff. So at least you'll be
Dr.
able to.
Maraska.
Oh, okay. Yeah.
Yeah. Sorry.
That's okay.
Yeah, they're really good. It's a lot.
A lot of stuff. And it's kind of like learning a language. But if you understand it, even if just you understand the basics, and even with that that little P thing, if you understand things like that, that will help you better understand when you're reading the literature, the actual research literature. Maybe you don't understand all the real sophisticated, all the nuts and bolts of it, but you get the big picture, you can better understand it. And you can say what's a good study and what's not a good study. That will really help you overall. So you guys are starting to nod, starting to get late. Any other parting questions? Okay, I think what I'm going to do for the rest of this semester, I'll probably have at least one Zoom every other week, if not every week. The next, let's see, we got the paper due. We got a couple other assignments due. The last one that we have is that the simulation stuff, the process stuff and things like that. I really want to have at least one, if not two or more sessions just to kind of go through. There's a little software that you download and then you actually work and set the thing up. So I'll plan on having that. We've got Thanksgiving coming up. So I think we're out for most of that week, but we'll work around that. Is anyone traveling for Thanksgiving this year? It sounds like we're all supposed to stay home. Okay, batten down the hatch, but.
My wife just picked up a job in Virginia, so we're going to be taking her out there.
You're going to Virginia? Oh.
Yeah, I'm gonna help her drive out there to drop her off. She just got a nurse midwife job.
Oh, great. We're in Virginia.
Fairfax, I think.
Yeah, Fairfax. Yeah, that's up. That's up near the Beltway. Yeah. Yeah, good. Great. Well, hope she likes it down there. It's kind of crowded and there's all these creepy people inside the Belt. That's a whole other story. But yeah, good. And then you're coming back. You're going to stay here to finish, or?
Yeah. I'm staying here. We're going to be on two ends of the country. Well, I'll be in the middle of the country. She'll be on the other end of the country. So, yeah.
Okay, going to coin a new phrase: zooming relationships. Huh? Zooming on each side. Good night, honey. See you. Bye. Or you're down the car. You driving around. Oh, yeah, yes. All right. Yeah, I'm starting to deteriorate here, so we'll wrap it up. So I'm going to stay online here for just a few minutes. Someone wants to talk to me, but great. Thanks. Thanks for participating. And Nadia, I think what I'm going to do is open up a second Zoom because I have to close this so it can render before I can upload it. So let's do this. I'm going to set up a second Zoom and I'll send you an email with the actual code on it. Because that's the
Sounds
only way I can do that without recording or, something like that. So anyway, thanks guys. And I'll be right back, and have a good one. See ya. Stay away from Starbucks. The bad things to your heart. Bye-bye.
Thank you.